Dear colleagues, good morning, good afternoon. Let me greet all of you on behalf of all co-chairs in the most exciting part of our forum, Young Scientists Award. I'd like to tell you that the Russian Society of Cardiology helps our young scientists to acquire essential skills aimed at achieving great results in mastering the art of presentation. We hope, dear colleagues, that ahead of you is participation in European congresses, where you will present your original data and represent your scientific teams. All of us wish you a great success and good luck today. And it's a great pleasure for me to introduce our first speaker, Galenko V.L, junior researcher of Scientific Department of Heart Failure, Almazov National Medical Research Center, St. Petersburg, who will talk on effect of aerobic physical rehabilitation on muscle tissue metabolism in severe heart failure patients.
Да, все верно. Yes, can you see my slides?
Yes.
Thank you. Thank you. Good day, dear chairpersons. Good day to everyone. I'd like to tell you about effects of aerobic physical rehabilitation on muscle tissue metabolism in patients with severe heart failure. There is no conflict of interest and I have nothing to declare. It's widely known that heart failure affects every organ, every tissue in human body, and of course it affects muscle tissue. It leads to high lactate levels in venous blood, which activates and hyperactivates metabolic reflex, which leads to abnormal regeneration program of muscle fibers and, in the end, to muscle fatigue, exercise intolerance in heart failure patients, and physical rehabilitation can help us to improve this problem, this situation. The purpose of our study was to evaluate efficiency and safety of aerobic physical rehabilitation based on original method and to study morphometric and metabolic changes in skeletal muscle fiber after physical rehabilitation. On this next slide, you can see inclusion and exclusion criteria. Let me please be brief. I'd like to note that we included only patients with reduced ejection fraction and stable patients with stable phase of heart failure. On this next slide, you can see that 100 patients were included. All patients underwent echocardiography, cardiopulmonary exercising test, and were assessed quality of life and exercise tolerance using questionnaires. And we repeated all assessment each 6 months, and shin muscle biopsy was taken only from patients who signed special form of informed consent. Cardiopulmonary test was performed on treadmill using ramp protocol, and we evaluated standard values, and lactate threshold achievement was assessed by changes in ventilatory indicators and lactate levels in venous blood as well. Shin muscle biopsy was taken from 13 heart failure patients, and it was performed at baseline before start of our program and after 3 to 6 months of training program. And it also was taken from 11 healthy volunteers only once. Then muscle samples was used for histological and histoenzymological examination. We assessed alkaline phosphatase lactate dehydrogenase activity, and stem cells isolation and transcriptome sequencing analysis was performed before start of our training program and after 6 months. Our physical training program included dosed walking. Its velocity or its intensity was 90% of physical effort or velocity on lactate threshold achievement during cardiopulmonary exercise and test. We used lactate threshold because it is the first phase of glycolysis activation, and while patients training under lactate threshold achievement, it doesn't lead to high levels of lactate in patients' blood, and it helps us to prolong time of training. On this next slide, you can see patients' main characteristics. Most of our patients were male. Most of them had ischemic heart disease. And approximately 26% of our patients had different implantable devices. On this next slide, you can see laboratory and clinical characteristics of our patients. Let me be brief. I'd like to note that all our patients were stable, and laboratory and clinical characteristics as well were stable. I'd like to note that all patients received in our program included in our program received optimal drug therapy, beta blockers, ACE inhibitors, and all patients received loop diuretics and MRA, and 15% of our patients received simultaneous scheme of diuretics, including hydrochlorothiazide and or acetazolamide. It was patients who had most severe symptoms of heart failure. And I'd like to tell about our results. Planned period of training was 12 months, average period of training 15 months, and more than 12 months, 27 patients were trained. As you can see, during 24 months, we had only 8 hospitalizations caused by heart failure decompensation, and only 2 patients died because of heart failure progression, and 6 of our patients underwent heart failure transplantation. Left ventricular ejection fraction dynamics. Left ventricular ejection fraction mostly increased after 6 and then after 12 months. And between 12 to 24 months, it was stable with no significant change. Quality of life will improve in the whole period of training, and after 24 months, it changed by 33.4 points. It was significant change in our patient's condition. Exercise tolerance was improving the whole period of time as well, and after 24 months it changed by 12.2 points. Peak oxygen uptake, the most significant marker of patient's prognosis of patient's exercise tolerance. Peak oxygen uptake in our study was increasing the whole period of time, and after 24 months, it changed by 6.7 milliliters per minute per kilogram. It was significant change for our severe patients. I'd like to draw your attention on this next slide that 21% of our patients managed to completely cancel diuretic therapy by 12 months of our program or physical training. I'd like to note that enzymes activity in muscle fibers change significantly too. First of all, alkaline phosphatase as marker of endothelial function, marker of microvascularization of microcirculation, changed. It increased by 24.2%. It was a significant change. And lactate dehydrogenase decreased, its activity decreased in glycolytic fibers by 24.4%. It was significant change, and in oxidative fibers we didn't find so significant change. It was only by 6%. I'd like to note that lactate dehydrogenase is enzyme of glycolysis of glycolytic metabolism. On this next slide, I'd like to talk about signaling pathways in heart failure patients. It's our results. And I'd like to tell that most of signaling pathways in our patients are damaged, are injured. And first of all, muscle contraction, circadian rhythm, cell cycle, cycles of regeneration program. So it leads to a normal regeneration program, which doesn't end in normal muscle tissue. And after physical rehabilitation, we can see that most of these pathways, it's red color, are repaired, and we can say that catabolic processes are repaired as well. It's down regulation in blue color, you can see. And in conclusion, I'd like to say that aerobic physical rehabilitation in stable heart failure patients was effective in improving values of left ventricular ejection fraction, quality of life, peak oxygen uptake, and exercise tolerance. Participating in our program decreased lactate dehydrogenase activity, and it also increased alkaline phosphatase activity significantly, and this may indicate increase in oxidative metabolism, decrease in glycolysis, and improvement in skeletal muscles, microcirculation, and endothelial function. And about signaling pathways, I'd like to note that exercise-induced increase in exercise tolerance heart failure patients was associated with activation of signaling pathways responsible for skeletal muscle regeneration potential. And I'd like to note for normal regeneration processes, pre- and post-exercise transcriptome sequencing analysis indicates that training-induced muscle regeneration and muscle function in heart failure patients. And skeletal muscle stem cell in heart failure patients, it's very important finding. It retains its differentiation potential, so we can note that skeletal muscle stem cells from patients with heart failure, even with severe heart failure, it's not much differ from stem cells of healthy people, and it is the regeneration potential of skeletal muscles. So thank you for your time. Thank you for your attention. I'm ready to answer the questions if there are.
Thank you. Thank you, Victoria, for your brilliant presentation. You sounded confident and very energetic, I would say. But I want to note that you included in the study 18 females. Yes. So my question is, why you don't include males in your study? It's maybe an issue of compliance.
No, it wasn't our desire. It wasn't our plan. We included male and female patients. It wasn't our plan to include more male patients than female, but I'd like to note that in big trials and big studies, female are not so common. I can comment this situation. I don't know how to say. It just was the situation that male. I don't know how to say it better. Most of our patients were male. It's I guess it's situation in the world that female are not so good presented in big studies and in studies in physical rehabilitation.
Thank you. I think in the near future you could perform some comparative analysis between males and females. Any more questions, dear colleagues?
Yes. Can I ask you for one question, please? Thank you very much for your nice presentation. And my question will be related to oxidative and glycated results. So you showed that oxidative results were not statistically significant when compared to our glycated results. So, but if maybe I'm wrong, but as far as I know, that glycated, it's about anaerobic process, and oxidative, it's about aerobic process. Mm-hmm. So does that mean that your results show that anaerobic process is better in for rehabilitation than oxidative process?
Thank you for your question. It's a very, very good question. No, it's not so, because we found that lactate dehydrogenase, its activity decreased. So it shows us that activities of glycolysis in our patients decreased too. And it means that oxidative processes must be better in our patients. It shows us switch from glycolysis to aerobic processes in our patients, and alkaline phosphatase shows it as well. So we can say, we can think that in our patients, we can see better microvascularization, microcirculation, we can see better endothelial function, and a switch from glycolysis, anaerobic processes, to normal oxidative processes. I didn't include in this presentation results of succinate dehydrogenase, because this enzyme shows oxidative processes, and we found that oxidative processes, activity of succinate dehydrogenase increased as well in our patients.
Thank you so much for your answer.
Thank you. Maybe I'm a little bit nervous.
All is well. You're brilliant. Thank you.
Thank you.
Sorry, I would like also to ask one question. If we have time, I will be short.
Sure, yeah.
Yeah, I want to congratulate for the great presentation. I just have two really short questions. First one is if BMP also was measured, and do you have any data if you were investigating also the role of trimetazidine in oxygenation, tissue oxygenation? Do you have any data about that? Due to the fact that obviously you had also ischemic heart disease, you have also the exclusion criteria that you mentioned, but definitely you have ischemic heart disease in these patients. So do you have any data about the use, improvement of trimetazidine also, maybe?
Thank you for your question. We didn't measure role of trimetazidine in this study, but before we had group of patients, and they with ischemic heart disease and with dilated cardiomyopathy, and they received trimetazidine, and they showed better results in peak oxygen uptake than patients who didn't receive trimetazidine. It was patients with ischemic heart disease and with non-ischemic genesis of heart failure, patients with dilated cardiomyopathy. And in this study, we didn't measure it. It wasn't our goal to look at it. And about BNP, of course, we measured NT-proBNP, and in our patients, we found, of course, it was a decrease of it, and it was a rather significant decrease. I didn't show it. It's my mistake, maybe. I decided to talk about metabolism, and I didn't include BNP. Thank you.
Thank you.
So may I ask one question, please? I think that maybe it will be the last question for you because we have a limit of time. You showed us that the mean value of ejection fraction was about 27%. So as I understand, a lot of these patients should stand in the transplantation, heart transplantation list. Видео у меня включено.
Irina, thank you for your question. Of course, it's a good note. Many of our patients had severe heart failure, third functional class of heart failure, and some of them were included in list of heart transplantation, and 6 of them underwent this intervention.
So this program extends the time to the transplantation. It's like a bridge.
Yes, we can say so. And for some patients, it helped not to underwent this procedure.
Mm-hmm. Thank you so much.
Thank you.
So I think that if we haven't any question, I want to ask Chernova and Alexandra, please, to present the next presenter.
Yeah, so one question for Victoria. Thank you for your report. Please tell me where were 11 health volunteers recruited and how were they examined?
Yes, thank you, Anna Alexandrovna. It was last stage of our program. We decided to include 11 healthy volunteers for to have material to compare stem cells from healthy people and to patients with severe heart failure. Healthy volunteers, they underwent muscle biopsy too, but from them was taken samples which were smaller because we didn't need histological and histoenzymological histoenzymological examination, and we needed only stem cells isolation. And about examination of these healthy volunteers, they didn't underwent echocardiography. We performed cardiopulmonary exercising test and some laboratory analysis, hemoglobin, potassium in venous blood, level of glucose, and it's all. We didn't examine them very widely. It was male subjects and 18 to 25, 26 years old. They reported they were healthy, they had no any conditions, so we decided that it will be enough to take some blood samples and to examine their exercise tolerance.
Thank you, Victoria. I understand you. And I want to introduce our next speaker, Elizaveta Skorodumova from St. Petersburg. The value of the time of I explain because I works from telephone and from my phone, and I read program from telephone. I'm sorry. Maybe Irina introduce next speaker.
I would like to introduce the next speaker, and the next presentation will present the Skorodumova Elizaveta from St. Petersburg. The name of the report is the value of the time of isovolumetric relaxation of the left ventricle as a prognostic factor in acute conditions in cardiology. Thank you. So you're welcome. Необходимо выключить демонстрацию экрана, Виктория, пожалуйста. Видео не будет, потому что экран включена с телефона.
Хорошо, я вас понимаю.
We would like to draw your attention. Sorry, dear colleagues, good morning. We would like to draw your attention to the assessment as a simple parameter which constantly determined as an important prognostic marker like AVRT in unfavorable prognosis. I have nothing to conflict to declare. Exist 6 types of markers: is hemodynamic, clinical, functional, metabolic, systemic inflammation, and myocardial fibrosis markers. And AVRT, it is hemodynamic, functional, and myocardial fibrosis markers. IVRT, it is changes in myocardial tightness on the background of the mitral valve closure. Due to Elvis remodeling, it is wall stiffness increases as well as pericardium and coronary arteries. LV IVRT is associated with myocardium's relaxation and generally is determined by hemodynamic overload. If blood pressure in aorta elevated, IVRT increases. If blood pressure in left atrium elevated, IVRT decreases. Elevation if input pressure reduced outflow left atrium that reduced blood outflow in pulmonary circulation. That reduced pulmonary circulation and causes of lung congestion. Our purpose was evaluated to the LV-IVRT's role as a predictor of unfavorable outcome in patients with acute heart failure. Inclusion criteria was a patient admitted to the hospital for the acute heart failure, aged over 18 years, with a history of coronary heart disease, hypertension, episodes of atrial fibrillation. Diagnostic of acute decompensation of heart failure was based on a typical clinical presentation, at least of shortness of breath, distension of ventricular veins, hepatomegaly, lungs congestion detected clinically or radiologically, peripheral edema, ascites. Exclusion criteria are presented into the slide. The study included 121 patients aged from 37 to 85 years. Most of patients were males. Average duration of chronic heart failure was about 6 years. Follow-up was evaluated for 2 years. According to the level of LV-IVRT, general group was divided into 3 subgroups. In low IVRT is less 70 milliseconds, it was 15 patients. In normal IVRT group, it was 70 to 100 milliseconds, it was 54 patients. And in high IVRT group, it's over 100 milliseconds, it was 52 patients. The mean value in low IVRT group, it was about 55 milliseconds. In normal IVRT is about 87 milliseconds, and in high IVRT group is about 166 milliseconds. In general group, 5 patients died during the hospital period. The immediate cause of death were pulmonary thromboembolism or progressive of acute heart failure. In follow-up period, it was 36 patients, and immediate cause was myocardial infarction, pulmonary thromboembolism, progressive ADHF, and non-cardiac causes was the reason of death in 2% of cases. Mortality in subgroups has statistically a difference between low and other AVRT group in hospital mortality, and in follow-up period it was between low and normal AVRT group with high AVRT group. In the correlation analysis, we have a negative association with a middle strength between low AVRT and mortality. In long-term period, there are correlation with medium strength with mortality rate in low and normal AVRT. This allowed us to apply a linear regression to assess the effect of AVRT on mortality. This results in histogram of regression residuals. This histogram is generally symmetric, which indicates a good predictive value. This slide demonstrated the PP plot who predicted values almost deviated from the predicted ones, which high specificity and sensitivity. R square was 0.677, and the predictive value was the predictive value of AVRT as predictor of the death was verified using bioanalysis. The area under curve was 0.78, which is characterized by a rating of the good in the expert scale of the high specificity and sensitivity. Our conclusion: low AVRT in patient with ADHF has a negative correlation with a hospital and long-term mortality. Low AVRT predicts high cardiovascular mortality and hospital stage. Low and normal AVRT are markers of the cardiovascular mortality and 2 years follow-up. Thank you for your attention.
Elizaveta, thank you very much for your presentation. It's a very interesting report. Dear colleagues, do you have any question to Elizaveta?
I have several questions. Can I? Thank you so much. Elizaveta, thank you so much for your talk. And actually, I have, so the first, my question is, what was the main cause of heart failure patients in your study? Because I couldn't see there any data. So I saw there that there were males, but what's you? I'm sorry.
Thank you for your question. The reason of acute decompensation of acute decompensation of heart failure was myocardial infarction in anamnesis or arterial hypertension. How a reason for acute decompensation of heart failure, but it was in 6 years between myocardial infarction and acute decompensation of heart failure.
Thank you, but I wanted just to ask, what was the main, the prevalence of the main cause was myocardial infarction, right? That was the main, yes. The second question is about IVRT. So if we are talking about relaxation, what you didn't show here the left atrium pressure. Have you measured that or you didn't do that? Thank you.
Thank you for your question. Yes, we measure pressure in left atrium, but correlation with pressure in left atrium and IVRT is not significant.
I mean that if the IVRT is impaired, then the pressure of left atrium should be increased, and that left atrium also is predicting the mortality. So there was no difference, right? So.
Yes, they have a link between them, and in correlation analysis we can use IVRT or pressure in left atrium, but we cannot use both.
And another question, you showed that inclusion criteria was 2 over symptoms or signs for congestion, but what about markers? And the second question, what about ejection fraction? What was the criteria for them? Were they only reduced ejection fraction or also preserved as well? Thank you.
Thank you for your question. We have NE and laboratory criteria, and we measure ejection fraction. And all types ejection fraction have the same correlation with mortality and correlation with IVRT.
Thank you so much.
May I ask one more question? Елизавета, could you please show us your data on mortality? You divided your patients into 3 groups according to the value of IVRT, but you showed that 35% of patients died from pulmonary thromboembolism. Can you explain this matter? These findings?
In lung congestion of such patients have lung congestion. With lung congestion, higher risk of pulmonary thromboembolism. And most of patients have a diuretic therapy, and that increase risk of the pulmonary thromboembolism too.
Elizaveta, may I ask another question, please? I want to ask, what is your what is your role in this scientific work?
I examined these patients and all statistical work.
Thank you so much. Someone have another questions to Elizaveta? No, so the words are given to Amina.
Thank you so much. And it's my great pleasure to introduce our next speaker with a talk about peculiarities of cellular immunity in atherosclerosis. Filatova Anastasia from Moscow. And we are very, very welcome to hear you here. Thank you.
So, dear colleagues, good afternoon. It's a great pleasure to be here. Thank you for the introduction. I have nothing to disclose. Chronic inflammation plays the leading role in atherosclerosis. Innate immune cells, monocytes, macrophages, and adaptive immune cells, T lymphocytes, are involved in the regulation of the inflammatory process in the artery wall and possess protherogenic and antitherogenic activity. The aim of our study was to analyze the circulating pro- and anti-inflammatory subpopulations of lymphocytes and monocytes in patients with atherosclerosis to evaluate the immunotropic effects of statins. The research consisted of 2 parts. In the clinical part, we performed the detailed leukocyte immunotyping in patients with coronary and carotid atherosclerosis. In the experimental part, we investigated the influence of atorvastatin and rosuvastatin on migration, proliferation, apoptosis, and cytokine synthesis in the culture of human monocytes, macrophages, and CD4+ T lymphocytes. The different segments of the brachiocephalic arteries have heterogeneous hemodynamic and histological characteristics. The internal carotid artery is a distal part of the common carotid artery, and it has a smaller diameter. The blood flow in the common carotid artery bifurcation and the internal carotid artery is turbulent. The common carotid artery belongs to the arteries of elastic type, while the proximal segment of internal carotid artery is a muscular elastic type. These features can determine the differences in the mechanisms of initiation and progression of atherosclerosis in different parts of carotid arteries. The increased content of circulating T helper 17 was associated with the severity of atherosclerosis in the distal muscle, but not elastic parts of carotid arteries. In the one-year prospective study, the imbalance between regulatory T cells and T helper 17 with the predominance of pro-inflammatory T helper 17 was the risk factor for the progression of carotid atherosclerosis in normal lipidemic patients. Age-related declines in the immune system are an important factor promoting the activation and maintenance of a chronic inflammatory process. We revealed that in older patients, the number of circulating CD4+ T cells and regulatory T cells was decreased. Weak but significant negative correlations were found between age and the number of CD4+ T cells, regulatory T cells, including naive subsets expressing CD45-Ra. We examined the phenotype of circulating monocytes in patients with coronary atherosclerosis, depending on age. Patients were categorized into three groups, according to the severity of coronary atherosclerosis, assessed by angiography, and into two groups, depending on age, above or below the median 60 years old. Advanced stages of coronary atherosclerosis were associated with increased values of intermediate monocytes in younger patients and with decreased quantity of classical monocytes in patients of the older age. The values of non-classical monocytes were not associated with age or coronary atherosclerosis severity. Statins are currently the main group of drugs used for correction of lipid spectrum in atherosclerosis. Additional anti-inflammatory effects have been demonstrated for some of them. Based on the data on the pleiotropic activity of statins, we assessed their effect on immune parameters. Short-term intensive atorvastatin therapy was associated with a significant increase in the content of regulatory T cells and with a decrease in the expression of chemokine receptors by circulating monocytes. We compared the influence of atorvastatin or rosuvastatin therapy escalation on the parameters of cellular immunity in patients with the indication for intensive statin therapy. Atorvastatin therapy escalation was associated with a significant increase in regulatory T cells to T helper 17 ratio and a decrease in activated T helpers to regulatory T cells ratio. Both were predominantly due to an increase in regulatory T cells. Rosuvastatin therapy escalation wasn't associated with any changes in immune cell populations. In the culture of CD4+ lymphocytes, the dose-dependent inhibition of cell proliferation by statins was observed. The effect of atorvastatin was manifested at lower concentrations compared to rosuvastatin. While the proliferation of effector cells was impaired, the relative content of FOXP3+ regulatory T cells increased. Pre-incubation of lymphocytes with atorvastatin resulted in a decrease in the spontaneous and ISDH1-induced chemotactic activity of cells. The suppression of chemotaxis by statins wasn't associated with a change in membrane density of chemokine receptors, but was apparently due to a decrease in cell motility itself. We assume the immunological changes observed in patients receiving atorvastatin were associated with the suppression of migration and proliferation of effector T cells. Microscopic analysis on macrophages obtained from human blood monocytes showed that after 6 days of incubation with GM-CSFs, cells spread out on the plastic, taking a rounded or elongated shape. Addition of statins to culture media prevented size increasing and spreading of cells. Many of them retain a spherical shape. At the same concentrations, the effect of atorvastatin was more pronounced than effect of rosuvastatin. The content of cytokines in culture media of macrophages pre-incubated with statins and activated with LPS interferon gamma was lower compared to the control without statins. Statins did not stimulate apoptosis of macrophages after activation. Moreover, pretreatment with atorvastatin and to a lesser extent with rosuvastatin suppressed LPS interferon gamma-induced activation of caspase 3 in cells. So, to summarize, immunological changes observed in patients, in particular a shift in the regulatory T cells to effector T cells ratio with the prevalence of pro-inflammatory component are observed at all stages of the atherosclerotic process and are associated with a severe, unstable, and progressive course of the disease. The risk of atherosclerosis progression after correction of dyslipidemia may be associated with pro-inflammatory status. The contribution of immune inflammatory mechanisms to the development of atherosclerosis depends on age. An intensive regimen of atorvastatin therapy is associated with immunomodulatory or anti-inflammatory activity due to direct effect on immune cells. The more pronounced immunotropic activity of atorvastatin may be associated with its lipophilicity. And this is my last slide and my contributors, and thank you for your attention.
Anastasia, thank you very much for your interesting presentation. If it's possible, I want to ask the first question. So, as I understand, you're working in the experimental part of National Medical Center.
Yeah, it's
right. And exactly what are you doing? What the input in this work?
My part in this work.
Yes.
Actually, this work started a few years ago. I started doing this in 2015 year, firstly, of course, I was taking material during my residence period, where I was managing patients, and then I continued working in laboratory cell immunology and doing my experiments, which I was presented in cell culture and immunotyping of leukocytes. So, I think I can say that I do all this work.
How many years do you work?
Do you mean how many years I work with this data?
This, yes.
Yeah, the work was started in 2015, and it was finished last year.
So, Anastasia, could you say to us, maybe I skip this information, why you use only atorvastatin? You assess also rosuvastatin, but why not some new molecules from statins or different doses and etc., combined therapy?
Yeah, here in our work we used atorvastatin and rosuvastatin because they were the most used drugs for patient management with dyslipidemia. So we used these two drugs, as one of them is like lipophilic agent, and others, rosuvastatin, as hydrophilic agents. They have different physical chemical characteristics. So they used both only these drugs because others they have or more close. They are or more closely to atorvastatin or to rosuvastatin. So we used only these drugs. Did I answer?
I see. Thank you so much. And do you have any questions?
Sorry, I would like also to give a suggestion. Actually, it wouldn't be a question. Do you plan maybe also to make some kind of follow-up with patients after COVID when talking about cellular immunity and its influence on atherosclerosis and vascular aging? Because now there is one new study, Cartesian study, which will actually investigate the influence of COVID on vascular aging. So I would like to ask you if you're also planning maybe to follow the patients after COVID.
Thank you for this very good suggestion. Actually, we didn't think about this, but it's very interesting question, I think, and maybe we'll think about.
Yeah. Okay. Thank you.
So if we haven't any new questions, I want to give a speech to Melissa, and she will present the next speaker.
Yes, actually, thank you for this great presentation. I would like to introduce the next speaker. It's Babina Anastasia. She will talk about diagnostic value of parameters of global myocardial work in patients with STEMI. So please, you can start with your presentation. Thank you.
Good morning, colleagues. It's a pleasure to present to our results today. This is my conflict of interest. Ejection fraction is a traditional parameter for assessing the left ventricular systolic function, but ejection fraction doesn't reliably reflect the contractility of the myocardium always. Myocardial infarction leads to left ventricular.
Sorry, I would like also to give a suggestion. Actually, it wouldn't be a question. Do you plan maybe also to make some kind of follow-up with patients after COVID? When talking about cellular immunity and its influence on atherosclerosis and vascular aging, because now there is one new study, Cartesian study, which will actually investigate the influence of COVID on vascular aging. So I would like to ask you if you're also planning maybe to follow the patients after COVID.
Thank you for this very good suggestion. Actually, we haven't. We didn't think about this, but it's very interesting question.
У нас включился повтор каким-то образом. Как это убрать? So it will be a good idea. Okay.
Sorry, I would like also to give a suggestion.
Myocardial infarction leads to left ventricular remodeling and change in myocardium pumping function, but ejection fraction may remain normal. The speckle check in echocardiography with global longitudinal strain assessment has several limitations. One of it dependence on the heart afterload during the study. Evaluation of myocardial work in patients after STEMI may be more reliable to assess in assessing of left ventricular systolic function. The study of the myocardial work began in the 60s of 20th century by Eugen Braunwald, but it was not possible to assess the parameters of myocardial work due to the imperfection of the equipment. Russell's scientific group proposed an approach that allows to evaluate the myocardial work with the pressure strain loop. To construct the curve, the global longitudinal strain and pressure measured by Korotkov method are used. The following indicators of myocardial work are evaluated. Global work index is a total work from mitral valve closing to mitral valve opening and equal to the area under the pressure strain loop. Global constructive work is a total work for shortening during systole and elongation during diastole. Global wasted work is a work for elongation during systole and shortening during a diastole. And global work efficiency is a fraction of constructive work to total work. Our research objective was to identify differences in the STEMI and in healthy individuals. In the study were included 45 patients with primary STEMI, 8 women and 37 men with age of 32 to 64 years. Myocardial infarction was confirmed by electrocardiography results and diagnostically significant level of cardiospecific markers, and by the results of coronary angiography with the presence of one infarct-related coronary and the absence of hemodynamically significant stenosis of other arteries. The control group included 58 healthy individuals with an average age of 47 years. Inclusion criteria were no complaints, analytic and physical data indicating the presence of cardiovascular diseases and or damage to other organs and system, electrocardiography without abnormalities, and no regular intake of any medications. And exclusion criteria were diseases of cardiovascular system, respiratory system, chronic diseases of kidneys and liver, type 1 and type 2 of diabetes mellitus, hypoglycemia equal or above 6.1 millimole per liter, dyslipidemia, 30 kilograms per square meter, and poor echogram visualization. Echocardiography was performed on 6 days after STEMI and 6 months after index event. Standard echo parameters were determined: anti-systolic volume and systolic volume, left ventricular mass index, left ventricular relative wall thickness, and ejection fraction by the Simpson-Beplan method. The value of this indicator was considered to be preserved by more than 50%. The following indicators of myocardial work were evaluated: global work index, global constructive work, global wasted work, global work efficiency. Heart failure was confirmed by the results of 6-minute walk test performed 6 months after the index event. 6 months after STEMI, 26 people had a value of ejection fraction equal or above 50%. In this group, we performed a 6-minute walk test, and the average distance traveled in 6 minutes was 410.7 meters, which corresponds to the second function class by New York Heart Association. In the HFPF group, the indicators of EDV, ESV, left ventricular mass index were significantly higher than in healthy individuals. The ejection fraction was not significantly different. The indicators of global constructive work, global work index, global work efficiency was significantly higher in healthy patients, and global wasted work were naturally higher in HFPF group. Thus, the indicators of myocardial work, except for the global wasted work, had lower values in patients with HFPF in contrast to healthy ones, despite the normal values of ejection fraction. Indicators of myocardial work may more reliably reflect the state of the myocardium after previous ST elevation myocardial infarction compared to ejection fraction. Thank you for your attention.
Thank you very much for your report. It's good. It's very nice experience from Penza. And could you tell us, please, do you use this technique, these methods in every patient in your center or only in the scientific sphere? Anastasia, can you hear me?
Yes, thank you for your question. Yes, we used this technical, in scientific sphere of
Can I just one comment, or just to clarify one thing. You told Anastasia that heart failure was confirmed by 6-minute walk-in test. Is that correct? But what about symptoms and signs? What about that? I mean, in these patients?
Yes, this patient has dyspnea or complaints of Oedipus, dizziness, and low tolerance to physical activity. And
it's just my suggestion to you to include this for your investigation, because it's very important. A 6-minute walk-in test, it's a functional, functional capacity of patients with heart failure, but we are not making a diagnosis by 6-minute walk-in test, right? Thank you.
Thank you.
And also we have a question from Chernova Anna Alexandrovna. Because of the absence of the video, we have it in our chat. Dear Anastasia, could you answer on this question? What is your personal contribution to the research, and what research do you do by yourself? So what part of your research do you do by yourself? Thank you.
My contribution to this research, my part of this research was to include healthy patients and echogram performed, and statistic analysis of our data.
Thank you so much. Do you have any questions? Any more questions? Tia Tamil Vitalyevna, can I ask you to present the next investigation?
Yes, sure, dear colleagues. Let's invite Dr. Just a moment.
After Babina.
Yana Alekseeva, is that right?
Yes.
Yana Alekseeva, from Tomsk, cardiologist of the Emergency Cardiology Department, Research Institute of Cardiology, who will present data on the effect of microvascular injury, various types of left ventricular disorders by echo on long-term period after myocardial infarction with STEMI.
Good day. It is a great pleasure for me to deliver a presentation today. Mortality associated with STEMI has steadily declined in the past 40 years because of improved pharmacological treatment and the introduction of PCI. And now we see that 1-year cardiac mortality in STEMI patient amount nearly 8%. However, morbidity due to post-myocardial infarction, heart failure remain significant and is on the rise. And unfortunately, we still have not enough information about all mechanisms which lead to different types of left ventricular remodeling and outcomes after myocardial infarction. Definitely, according with guidelines of patients with STEMI, the most important is to early provide PCI. The success of coronary reperfusion therapy in STEMI is commonly limited by failure to restore microvascular perfusion. And intramyocardial hemorrhage and microvascular obstruction or no reflow phenomena represent components of microvascular injury. Cardiovascular magnetic resonance has emerged as an important imaging modality for assessing this phenomena. And our purpose of our study was to analyze the long-term effect of microvascular injury, various type, on the structural and functional parameters of the left ventricle assessed by echocardiography in patients with primary STEMI. Study included 60 patients with primary STEMI reperfused within 20 hours after symptom onset. And our patient had 2 types of reperfusion therapy. It were pharmacoinvasive strategy and primary PCI. Inclusion criteria were men and women if they were older than 80 years, primary STEMI according with guidelines, reperfusion of infarct-related artery, and exclusion criteria were pulmonary edema, cardiogenic shock, prior coronary artery bypass grafting, or PCI. Also, previous myocardial infarction, decreased kidney function, severe comorbidity, and inability to undergo or contraindication for cardiac magnetic resonance. In this slide, you can see our design of our study, and cardiac magnetic resonance imaging was performed at second day after STEMI in everybody. And after, all patients underwent the standard echocardiographic protocol at the 7th day and 3 months after myocardial infarction. In this slide, you can see microvascular obstruction or no reflow phenomena, and it can be identified like a dark zone within the areas of hyper-enhancing on conventional late gadolinium enhancing. And in this slide, we can see intramyocardial hemorrhage. In this situation, we use different regime, T2 waiting or T2 mapping, and also we can see dark zone. And our results. We observed that all microvascular injury, various type, were related by cardiac magnetic resonance in majority of the patient with reperfused primary STEMI. And after we divided all patients for 4 groups, and first group did not have any phenomena. Second group had only microvascular obstruction. Third group had only intramyocardial hemorrhage, and the most popular group had combination of intramyocardial hemorrhage and microvascular obstruction. The baseline characteristic of the subject are presented in this table, and the main parameters between the group were comparable except cardiac enzymes. It were higher in 2 groups, combination of phenomena, and in group of only microvascular obstruction. And in this slide, we also presented to you similar finding, and we see the same situation that also group with a combination of intramyocardial hemorrhage and microvascular obstruction had significant higher infarct size. And when we analyzed echocardiographic, we show that patients with combination of phenomena had much obvious changes. Like in this slide, we see that end-systolic volume was significantly high and patient with combination. In 7 days after STEMI and after 3 months. And opposite left ventricular ejection fraction was significantly lower in patient with combination of intramyocardial hemorrhage and microvascular obstruction. In comparison with patients without microvascular injury, isolated microvascular obstruction is associated with also lower left ventricular ejection fraction. And it was a surprise for us that patients with isolated intramyocardial hemorrhage, they have the same parameters of left ventricular ejection fraction. And after we did correlation analysis that show a relationship between microvascular obstruction and left ventricular ejection fraction, and also this correlation showed in ROC analysis, and we can see that the larger the area of microvascular obstruction leads to lower of left ventricular ejection fraction. And in conclusion, I want to say that the combination of intramyocardial hemorrhage and microvascular obstruction is a predictor of a reduction in left ventricular ejection fraction within 3 months after myocardial infarction. In comparison with patients without microvascular injury, isolated microvascular obstruction is isolated with lower left ventricular ejection fraction. And isolated intramyocardial hemorrhage was not associated with deterioration of left ventricular function. Thank you so much for your attention.
Thank you, Jana, for your elegant presentation. You combined echo and CMR in your study. I've got some questions for you. Let's start with long-term period of follow-up. Is it enough to call 3-month period long-term? What do you think? Maybe you've got some follow-up data to 6 or 12 months.
Thank you for your questions. Yes, it's a good question. And now we have results about 3 months. And I think that after we can show you different results, and after 6 and maybe 1 year, and we can show you more information about these patients, because it's a very interesting theme and very actual theme.
Thank you very much. You divided your patients into 4 groups, depending on the findings of CMR. But did your group differ in terms of therapy? It's known that glycoprotein 2B3A inhibitors may provoke myocardial hemorrhage in patients after STEMI.
Yes. This data was in literature about these drugs, and in our group we had only 3 patients who prescribed inhibitors of 2B and 3A receptors. All of these patients prescribed more or less similar treatment.
Thank you. I advise you to focus on this clinical matter. I'm sure that this aspect will enrich your study and the results you will provide us in the near future. Thank you so much.
Thank you so much.
Dear Yana, thank you so much. And from Siberia, we are moving to the central Russian, and it's the Moscow, and the next presentation will be from Allahverdiev Elvin, Suleiman-oglu, with the report Assessment of Blood Oxygen Transport Function in Patient with Pulmonary Hypertension. So you're welcome.
Okay. So, can you hear me?
Yes, it's okay.
Good afternoon, dear Chairman, dear colleagues. In our study, there is no conflict of interest. So, pulmonary hypertension is a group of diseases characterized by a progressive increase in pulmonary vascular resistance and pressure in pulmonary artery greater than 25 mm Hg. In our study, we selected patients with rare life-sustaining form of PH, idiopathic pulmonary arterial hypertension, named IPH. In the absence of adequate timely treatment, IPH have high mortality rate comparable to malignant tumor, for example, lung cancer. It has now been proven that the pathogenesis of IPH is multifactorial, that includes various biochemical processes in different type of cell. It is important to understand that the entire complexity of these diseases is not only in pathogenesis, but also in complexity of diagnosis. The symptoms that we find when we examine patient are not specific, which usually complicate the earlier diagnostic process. The onset of weakness, pain, dizziness in patients with IPH is primarily due to decrease in cardiac output and impaired oxygen transport. After carrying out the main non-invasive diagnostic process, I mean echocardiography, chest X-ray, 6-minute walking test, lung test, we proceed the main method for diagnostic this disease. I mean catheterization of the right heart, where we can define the hemodynamic parameters such as MPIP, PVR, cardiac index, and also in right table, you can see the main characteristics of IPH patients and healthy volunteers. The study of molecular mechanism of IPH is associated with the new opportunities in assessing the severity of disease. Therefore, the confirmation of hemoglobin might be special interest. The changes in the conformation of hemoglobin caused not only by hemodynamics, but also by conformation of hemoglobin, which determines the ability to bind and discharge oxygen. In this regard, we controlled the changes in the conformation of prosthetic group of red blood cells in patients with IPH using Raman spectroscopy. Therefore, the aim of our study is to assess the conformation of ability of hemoglobin to bind oxygen in blood from the cubital vein of healthy people and patients with IPH. In the experimental study, we obtained that the erythrocytes and in the experimental study, we performed the Raman spectroscopy method for diagnostic the conformation changes of hemoglobin of 10 patients who were hospitalized in Department of Pulmonary Hypertension and Heart Disease. Also, in our study, we include 10 healthy people served as control group. Blood samples were taken from the cubital vein into vacuum tubes containing heparin. The ratio of intensities of the Raman spectrum bands was analyzed. Also, the Raman spectrum method makes it possible to investigate the state of hemoporphyrin both in whole blood and also in a suspension of erythrocytes. The main feature of Raman spectroscopy method is a simple sample preparation for assessing the ability of hemoglobin in native erythrocytes to bind and release oxygen. Also, we isolated erythrocytes to assess the effect of plasma components on oxygen transport function of red blood cells. Using the Raman spectroscopy, we obtained that the erythrocytes of the healthy people after excretion are more intensively saturated with oxygen than those patients with IPH. We also see that the blood of patients with IPH is characterized by a high content of desoxyhemoglobin, which may be associated with the hypoxia state characteristic of this disease. In our study, we use two ratio of intensity to detect some changes in conformation of hemoglobin. And in our results of Raman spectroscopy demonstrating the conformation changes of the hemoglobin in red blood cells, we can see that the ratio of intensity of the band 1375-1580 shows that affinity for ligands are different from control and patient with IPH. Also, the ratio of intensities of the grafts demonstrated that the decrease in the value of 1580-1550 ratio probably indicates the affinity for oxygen. It follows that the patient with IPH are characterized by more hypoxic state of the blood. For red blood cells, a lower oxygen saturation is characteristic, which indicates a lower affinity for oxygen in patients with IPH. This is probably due to changes in the structure of erythrocytes caused by a constant hypoxia state of these diseases. And in conclusion, in patients with IPH, with a typical hemodynamic picture changes, is the all hemoperfurin of hemoglobin oxygen releasing ability reverted. Also, the conformation of hemoglobin of red blood cells for cubital vein in control group and IPH patient are different. And in patients with IPH, the reverted changes in the structure of hemoperfurin might help to develop new diagnostic approaches for assessing the severity of the diseases using the method of Raman spectroscopy. Thank you. Thank you for attention.
Thank you so much. May I ask the first question, Irina Nikolaevna? Will you let me ask the question? Dear Elvin, thank you for your nice presentation. You used Raman spectroscopy as the central lab method in your study.
Exactly.
From your point of view, which advantages Raman spectroscopy has in comparison with analogs?
Okay, so one of the most advantages of the Raman spectroscopy method is that this method is highly sensitive to the substance it investigates. Also, the Raman spectroscopy can be used to determine the relative content of oxyhemoglobin and desoxyhemoglobin in whole blood. And also provides detailed information on the conformation and oxygen binding properties of hemoglobin, the ability of hemoglobin to bind and release oxygen, and the affinity of hemoglobin in intact erythrocytes, as I said before. And also we forces that the identified changes could probably could reflect the severity of functional impairments on the patient who have the idiopathic pulmonary hypertension.
Dear Elvin,
Thank you.
Thank you very much for a very interesting presentation. Also, I have one question. You told us that you choose only the cohort of patients with IPH, but why you didn't assess didn't make that method, didn't make this assessment in other patients with precapillary pulmonary?
Okay, I see. So thank you for a good question. So our work is like pilot study before no one evaluated the conformation of hemoglobin in patients with IPH. Of course, in future, in future, we have planned to compare our data with the severity of the diseases and include different forms of pulmonary hypertension. For example, the pulmonary hypertension with established etiology, for example, some congenital heart defect. And yes, we have some plan to add some new form of pulmonary hypertension. Yes, but not yet. In future, of course, we will do this.
Okay, thank you. And could you tell us, please, what is your contribution in this work? As I understand, you are the graduate student of the first year.
Yes, I'm first year resident in cardiology center. My contribution is I do all of this work. I mean, I analyze all data. Also, I use spectroscopy to analyze our results. So all experimental work and study was done by myself. Only right heart catheterization were made by surgery, not by me.
Elvin, thank you for your report. I have a question. Mm-hmm. How do you think what the significant are you hear me? Yeah. What do you think? What's the practical significance of your research?
Yes, thank you for the question. Yes, the main significance that we can detect the oxygen transport function of patient with IPH, and in future we also can evaluate the effectiveness of pulmonary hypertension specific therapy based on oxygen transport function, and in future also we can like
do you mean personific therapy?
Yeah, to affect
each patient.
Yes. We took blood from cubital vein before we start some therapy, and after that we can do one more and just evaluate it. Is the therapy was effective or not? Also, that this can be an additional method for diagnostic the severity of this disease.
I understand. Thank you.
Thank you.
Thank you so much. And let me introduce the next young investigator. It's Rineiska N. She's from Minsk, Republic of Belarus, with the report Left-ventricular non-compaction cardiomyoparthy, additional predictors of life-threatening events for selecting patients for cardioverter-defibrillator implantation. As I understand, we have a record of this report. Пожалуйста, включите запись. Rineiska.
Hello, my name is Nadia Rineiska. I'm scientific associate in Laboratory of Chronic Heart Failure in State Institution Republican Scientific and Practical Center Cardiology in Minsk, Belarus. The topic of my research is left ventricular non-compaction cardiomyopathy, additional predictors of life-threatening events for selecting patients for cardioverter-defibrillator implantation. I have nothing to declare. The purpose of this research is to determine predictors of life-threatening arrhythmic events in order to identify high-risk patients requiring ICD and CRTD implantations. This study included 155 patients with NCCM, 59 women, 96 men, and a median age of 39 years old. In addition to this standard examination, cardiac magnetic resonance imaging with lead gadolinium enhancement was performed. The median follow-up was 36 months. Endpoints of the study included life-threatening arrhythmic events, sustained VT, VF, requiring device implantation, ICD, and CRTD. The most frequent types of arrhythmia were ventricular premature beats, more than 500 per day in 64 patients. An unsustained ventricular tachycardia was observed in 54 patients, sustained VT in 15 patients, and permanent atrial fibrillation with episodes of non-sustained VT in 34 patients. Syncope was registered in 17 patients. Symptoms of chronic heart failure, functional class 3, in 28 patients. According to the echocardiography data, the median LV ejection fraction was 44%. According to the CMR data, 72 patients showed areas of myocardial fibrosis. The median volume of myocardial fibrosis was 13.2%. During the follow-up period, life-threatening arrhythmic events, sustained VT, VF, developed in 15 patients, among which 8 ICD and 7 CRTD were implanted as a part of the secondary prevention of sudden cardiac death. In order to determine predictors of life-threatening events requiring ICD and CRTD implantations, a univariate regression analysis was performed. As a new factor aimed at identifying patients at risk of developing adverse events, the indicator of the volume of myocardial fibrosis according to the LGE-CMR data was analyzed. All parameters which were statistically significant in the univariate regression analysis, and we see that syncope, non-sustained VT, ventricular premature beats, symptoms of chronic heart failure, functional class 3, and percent of myocardial fibrosis were included in the multivariate analysis, and their threshold values were determined. The level of fibrosis volume associated with life-threatening events was 30%. After reducing the factors, 3 factors associated with the high risk of life-threatening events that required ICD and CRTD implantations were finally identified. Based on multivariate analysis, we identified risk groups of life-threatening events. It is established that the high-risk group is determined by the presence of at least one unfavorable factor. In multivariate analysis, independent factors associated with the risk of life-threatening events requiring ICD and CRTD implantations are the following characteristics: the presence of syncope, the presence of a non-sustained VT, and the percent of fibrosis volume more than 30. Risk groups of life-threatening events were stratified based on multi-factor analysis. The 3-year event-free survival rate of the high-risk group was 77.8 plus minus 5.8%. The low-risk group had no adverse events during the entire follow-up period, and the 3-year event-free survival rate was 100%. So in conclusion, I would like to say that the analysis of this cohort of patients with NCCM showed that the volume of myocardial fibrosis determined by LGE-CMR has become an additional tool that can improve the risk stratification of adverse events requiring ICD-CRTD implantations in patients with NCCM. The developed model of risk stratifications of life-threatening events allows identifying high-risk patients for timely preventive measures. Thank you very much for your attention.
Nadezhda, thank you so much for your interesting report. Any questions, dear colleagues? So I want to ask one question. Why you choose especially MRI to assess the predictors? Why you didn't use the more less cost methods such as transthoracic echocardiography with using 3D or strain and etc.? Why especially MRI?
Hello, everybody, and thank you for this question. We choose this method of diagnostic because this research, firstly, was conducted as a scientific work, like near scientific work, yes, and the methods that were predominantly indicated were echocardiography and CMR, because LVNC without CMR we can put this diagnosis. CMR is very, very important diagnostic tool for LVNC.
Okay, thank you. And is it your PhD work?
Yes.
And are you doing MRI by yourself, or you're assessing the results and analyzes the data of MRI?
No, I'm not doing by myself. Thank you. MRI is performed by two specialists on the same tomography, but I analyze all the measurement, and as I said, LVNC, we have two criteria, Peterson and Jackie criteria. According to them, we put this diagnosis, and all the Jackie criteria, I mean the LV mass, I measured by myself.
Okay, thank you. Dear co-chairs, do you have any more questions?
May I? Dear Nadezhda, thank you so much for your presentation. Share with us, please, what is the scientific novelty of your study?
Thank you very much. I think this scientific novel for this study is, first of all, to investigate more deeply this cohort of patients, because they're totally uninvestigated in our country, for example, in Belarus, and to find the risk factors for them, because at the end, most of them, we see them with life-threatening events such as VT and VF, and with sudden cardiac death. So first of all, is to predict these events, to find these risk factors.
Thank you.
Vitalina, can I ask you to present the next investigation, please?
The next one is Nikita Zagorodnikov. Is it correct? Zagorodnikov, sorry. I'm so sorry. Let me introduce the next speaker, Nikita Zagorodnikov from the Scientific Research Institute of Complex Issues of Cardiovascular Diseases from Kemerovo. The use of OCT to assess predictors of early coronary bypass grafts dysfunction and atherosclerosis progression in native coronary artery 1 year after bypass grafting.
Thank you very much. So, what is optical coherence tomography? It is a modern method of intravascular imaging, which has adequate resolution and makes it possible to determine the thickness of the fibrous capsule of an atherosclerotic plaque. OCT also makes it possible assessing the atherosclerosis progression in vivo. In our one center pilot prospective observational study, we want to identify the predictors of early dysfunction of coronary bypass grafts and also assess the cardioprotective properties of autografts using OCT. 21 patients with chronic coronary syndrome and multiple coronary artery disease which underwent coronary artery bypass grafting were included in our study. All the patients underwent coronary artery bypass grafting with OCT of arterial and venous grafts, including the distal anastomosis and the conjugate segment of the target coronary artery in the early prospective period after surgical myocardial revascularization. It was about from 4 to 7 days after the procedure. And also we have follow-up 10 patients who underwent OCT 1 year later after capture. The mean follow-up of our patients, you can see it in the screens. I'm really sorry, colleagues, that I can't show you a lot of pictures because our OCT is broken right now and it is repairing, but I can show you a few pictures. There are very interesting cases. The first two. In one case, the resolution of 65% stenosis of the left internal mammary artery in the area of anastomosis with the left anterior descending area was noted due to relief of edema or maybe hematoma of left internal mammary artery. Here you can see it. And in another case, another patient, dissection was noted, dissection of left internal mammary and left anterior descending artery anastomosis was discovered. And OCT revealed a double lumen with the formation of a false canal and stenosis of it about 70%. Subsequently, stenosis in the anastomotic area decreased to 50%, with an increase of a true lumen almost twofold. Yes. In the third patient, there is an 15% stenosis decrease of obtuse marginal branch. In two cases, an increase of the lumen of the left anterior descending artery by 1.5 times is noted. Also, we've got cases of progression of left coronary artery stenosis and the right coronary artery stenosis distal to the anastomosis with a decrease in the area of the vascular lumen. It is important that a great extent of the progression of atherosclerosis was observed in the right coronary artery system, which had anastomosis with outer venous grafts. And in two patients, competing blood flow was observed between the left anterior mammary artery and left coronary artery pools, which resulted in the occlusion of lima in one case. So, our research team believes that OCT is informative method for visualizing morphological changes in the coronary arteries and coronary grafts. These changes can be associated not only with early graft dysfunction, but also with the progression of atherosclerosis in the native coronary arteries within the framework of the interaction of the conduit artery systems in the follow-up of patients. And of course, we truly believe that internal mammary artery has great potential for its cardioprotective abilities. Thank you for your attention.
Dear Nikita, thank you so much for your presentation. I have one question to you. Is it your PhD work?
It's a little part of my PhD work. It's prospective part.
Okay. And do you use this method in the routine practice in your city?
So, I want to say that this method is really unique. We have found only one as like a study like ours in Bakulev Center only. Worldwide, we haven't found any like this.
And how you can see the implementation of this method, of this technique in this cohort of patients in another region of Russian Federation and the need of it?
The need of it? Thank you for an interesting question. So, I think that this method is very important in science ways, but in practice, it is usable in stenting treatment, and the vascular surgeons use it for assessment of coronary stents.
Thank you. And any more questions, dear colleagues? Thank you very much, Nikita. So we will moving forward, and the last but not least, Orlova Anna from Moscow, from National Research Center for Therapy and Preventive Medicine, will present the report about Apple Watch Hype or Hope. So you're welcome.
Good afternoon, dear colleagues. Today I'm going to talk to you about the diagnostic potential of the Apple Watch in our clinical practice. I declare that there is no conflict of interest. We will pursue only scientific goals. Nowadays, there are smartwatches on the wrist of an increasing number of people that inform their owners not only about time, but also about the number of steps taken, the oxygen saturation, the frequency and rate of the pulse. One of the most significant development is ECG sensor that was created to detect such rhythm disorder as atrial fibrillation. Is this objectification of health helpful? How to operate correctly with the receiving information? I suggest looking at these questions on an example on Apple Watch example. Atrial fibrillation is the most common heart rhythm disorder in the population that significantly increases the risk of ischemic stroke and other thromboembolic complication and death from them. The frequency of atrial fibrillation detection increases with age. The vast majority of patients has asymptomatic arrhythmia. Unfortunately, often it is diagnosed after a previous cardioembolic stroke. According to the modern recommendations for the detection of atrial fibrillation, ECG monitoring is recommended for at least 72 hours in patients with transient ischemic attacks or ischemic stroke. It is recommended to consider the possibility of additional ECG monitoring using non-invasive monitors or implantable loop recorders in patients with cryptogenic stroke. Systematic ECG screening is recommended in patients at high risk of stroke or older than 75 years. However, Long-term ECG monitoring only slightly increases the frequency of detection of silent atrial fibrillation. In addition, the large percentage of the population remains out of sight, so the world community are faced with the task of finding the optimal screening method of paroxysmal asymptomatic forms of atrial fibrillation. As you can notice on this slide, smartwatches already are among the screening tools suggested by the European Society of Cardiologists last year. Thus, large technology companies are also involved in solving this medical issue. The most serious approach was taken by Apple, whose first development was a sensor that detects irregular heart rhythm and notifies its owner about it. Based on this development, the Apple Heart study was conducted. Its goals was to evaluate the ability of irregular pulse notification algorithm to identify atrial fibrillation. More than 400,000 participants were recruited, and the monitoring was carried out for 8 months through a special mobile application. Participants with a registered irregular rhythm were sent in 1 week ECG patch to analyze their heart rhythm and confirm or deny the presence of atrial fibrillation. The results of the Apple Heart study are questionable. 2,161 participants received notifications of irregular pulse, and please take a look at the right picture. We see that it mainly was males over 55-year-olds. Unfortunately, the majority of them refused to participate any further or were excluded for other reasons. And only 450 people returned ECG patches with recordings suitable for analysis, and 34% of them were found to have atrial fibrillation. The exact percentage of atrial fibrillation identified by the irregular pulse notification algorithm remained unknown. Probably the lack of physical contact interest of the participants made this study so vulnerable. Still, the Apple Heart study is the biggest study of a technology company, which provides a basis for further investigation in digital health. The Apple went further and developed a sensor that can record ECG, and with the latest models of Apple Watch are able to record an ECG in 1 lead and give a high precision conclusion about the heart rhythm, with advice to consult a specialist in case of atrial fibrillation detection. One must keep in mind that Apple Watch isn't a medical device, and a standard electrocardiogram is still important for making a diagnosis. To find out is this development relevant in our country, particularly in Moscow, our own observation were conducted. Patients with paroxysmal atrial fibrillation were examined, and doctors who treated them were interviewed, and the following data were obtained. 47 of 53 patients with paroxysm of atrial fibrillation were admitted because of deterioration in the condition without fixing the arrhythmia at home. 5 of them fixed a frequent irregular pulse with a tonometer. 1 patient fixed a frequent irregular pulse on the radial artery, and no one fixed arrhythmia on the Apple Watch. The interviewed doctors, cardiologists, intensivists haven't met patients with rhythm disorders recorded by the Apple Watch in their practice. To sum up, the search for the optimal screening method continues. Apple Watch at the present stage is not a common diagnostic tool, but in the future it may become one of the main screening tools for atrial fibrillation, provided that the number and the average age of users will grow. Educational programs for the population would be useful, and recommendations on proper interpretation of wearable device data should also be developed for doctors. Health is becoming the super value at the present stage of society's development, and the coronavirus pandemic has only reinforced this trend. The use of digital technologies in medicine is more relevant than ever. Apple Watches makes its users get interested in their own health, take responsibility for it, or even manage it effectively, and in some situations may become a helpful mediator in doctor-patient communication. Thank you for listening, and now if there are any questions, I would be pleased to answer them.
Dear Anna, thank you very much for this interesting data about the Apple Watch, and I was very glad to see that you demonstrated to us your results of your own research. As I understand, it starts not so far. Could you tell us, please, is it your PhD work? And the second question, where did you get the Apple Watch? It was the patient's thing, or you support the patients with these technologies?
Yeah, thank you for your question. It's definitely my first steps in science, and we've decided to start with an observation, not exactly the research, to understand better exciting situation in our country. So we didn't provide Apple Watches to our patient. We just look and observe.
Dear colleagues, do you have any more questions? So I think that we have our last presentation, and I want to say thank you so much for being here with us, because I think that it's a good opportunity to overview your fears and present your work in English on the Russian area. And I think that your next step, dear colleagues, will be in the international congresses and forums. We wish you good luck, and I think that all results you will hear today at 4 o'clock by Moscow time. And also I want to give the speech by Tamil Vitaly and then to Melissa
It's a great pleasure to be part of this contest for me. I really think we've had a great time today. And of course, all co-chairs took into account that you, dear colleagues, made your presentation online. It made your task today more provocative, and that's why we hope that next time you will have the chance to make your presentation personally, in person, and wish you good luck and great success.
And Melissa, please. On your sound, please.
I'm sorry. Spasiba. First of all, I would like to thank you for the invitation to be part of this great forum. Actually, all presentations were really great. We've heard a lot of things and really hot topics nowadays in the field of cardiology. So it was really my pleasure, and I'm really happy that one of you will have the opportunity to get for free. Maybe it's not good to say right now what's the grant, but to have a present from all of us as the best presenter of this forum. So I'm really happy that I participated here also as a co-chair, and I really hope that there will be the opportunity to collaborate in the future together in this field. Thank you.
Thank you so much. So I think that it's time to start a new symposium, and we will call each other in WhatsApp to maintain the results. Thank you so much, dear colleagues.